Welcome to Kaiser University SportsNet, home to the greatest sports medicine program in Orlando. Today on topic is an issue that is plaguing our female athletes across the nation, the female athlete triad, a term first coined by the American College of Sports Medicine in 1992 after many experts in the field started to notice a pattern among adolescent and young female athletes. The female athlete triad is composed of three distinct interrelated health conditions: disordered eating, also known as an unhealthy energy deficit, amenorrhea, which is irregular absent menstrual period, and osteoporosis, low bone mass. So let's begin with disordered eating. Disordered eating and unhealthy energy availability is irregular eating behaviors. The prevalence of clinical eating disorders among female elite athletes ranges from 16 to a whopping 47%. Energy availability is the amount of dietary energy for all physiological functions after accounting for energy expenditure from exercise. Some athletes may have disordered eating simply by unknowingly failing to attain their requirements to a lack of nutritional knowledge. But it's because of this lack of education, many of these athletes limit their proteins, carbohydrates, and fat intake. This deficiency in macronutrients, particularly essential amino acids and fatty acids, can be detrimental to the body's ability to build bone, maintain muscle mass, repair damaged tissue, and recover from injury. Inadequate caloric intake and an unbalanced diet relative to an exercise level leads us to our second component of the triad: amenorrhea or menstrual abnormalities. This can be seen in any female who hasn't started menstruating by the age of 16, who misses 3 consecutive periods, or has periods that occur at intervals of greater than 35 days. In women who participate in sports that emphasizes aesthetics or leanness, the prevalence of secondary amenorrhea can be as high as 69%. Amenorrhea can be caused by a variety of things and abnormalities, but most particularly energy deficit. The type of energy deficit caused specifically by energy availability is known as functional hypothalamic amenorrhea. And this happens because the suppression of the hypothalamic pituitary ovarian axis without any type of cause is most specific to stress and exercise. FHA is caused by an alteration in the gonadotropin releasing hormone pulsality, which in turn causes a disruption of the luteinizing hormone pulses from the pituitary and gonadal steroid release from the ovaries. Menstrual dysfunction can lead to multiple of negative consequences associated with hypoestrogenism. Estrogenism, big word. Females afflicted with this also have a low immune system and functional impaired skeletal muscle oxidative metabolism. Estrogen deficiency and malfunction leads us to our third and final portion of the triad, which is decreased bone mass density. The greatest accretion of bone mass happens when in puberty, and young female athletes with the triad, are at much greater risk for things like fractures and osteoporosis. Several different components contribute to bone strength, including mineral content and microarchitecture and bone remodeling. Bone remodeling or bone turnover is a constant process of bone formation and matrix development by osteoblasts and bone breakdown by osteoclasts. When this process is interrupted, the bone is weakened and more prone to injury. Healthy athletes tend to have a higher bone mass density than most non-bearing athletes, but that's not the case for someone who is suffering from a component of the female athlete triad. This puts females in a situation where it's more prone to occur. So with all of these three components, we have to ask ourselves, how can we identify this problem? How can we ensure prevention or recovery? Well, some key warning signs for each of these range from things like weight loss, weight fluctuation, fatigue, yellowing of skin, stress fractures, frequent sore throats, and many, many more. So the best way to handle prevention and recovery will be the screening and the treatment for the triad. First and foremost, the greatest challenge in treating young female athletes with a triad may be in making the initial diagnosis of the condition itself. One way to screen for this is pre-participation physical examinations or health checkups. It's also key to obtain a clinical examination if one or more of the signs present themselves with one component of the triad. Signs associated with the triad include things like bradycardia, hypotension, and hypothermia. Patients should be asked about their eating styles to include binge or purging, and for any other recent stressors. Given that this condition plagues our youth, social and psychological factors play a big role. A multidisciplinary approach may be needed in order to support, educate, and treat, as well as making sure you work with a primary care provider or a nutritionist. One of the key things that needs to occur first is to obviously modify a diet and exercise regime. A recommended increase of at least 30 kcals a kilogram of fat-free mass per day to resume menses alone. Vitamin D and calcium intake will also play a vital role in bone health, but all this cannot be done by the athlete alone. Many young female athletes are resistant to weight gain and an alteration in their exercise regime out of fear and lack of education. Drug treatment may be a possibility with this, but that's not all of it. Most importantly, above all else, above all the screening, um, prevention is necessary for this to occur, and that's going to take vigilance on both the athlete and the coaches. Aside from that, and aside from vigilance, our athletes are going to need support in treating this, and that involves a multiple approach by many different people involved in that athlete's life. So this is something that is not just for the athlete alone to deal with, but for everybody else around them and involved in that sport. So just a little bit of information on the female athlete triad. So this is Jessica Callie reporting from Kaiser University Sportsnet.